Good afternoon, everyone. My name is Dr. Jodie Guest. I'm an infectious disease epidemiologist and professor and vice chair in the Department of Epidemiology at Rollins School of Public Health here at Emory University. I lead Emory's COVID-19 outbreak response team working in harder hit communities across the state of Georgia and am the host for Emory's COVID-19 videos where we talk about the latest news in the pandemic. Today, I'm pleased to be joined by my friend and colleague, Dr. Carlos Del Rio, so that we can update you on what's been going on most recently, including what's up with the Omicron variant. Dr. Del Rio is a distinguished professor of medicine, epidemiology, and global health at Emory, and is the Executive Associate Dean of Emory University School of Medicine at the Grady Health System. Good afternoon, Dr. Del Rio, and thank you so much for joining me again.
Happy to be with you.
Thank you. Quickly, here's a look at where we are with COVID-19 across the United States. Nationally, although not in every single state, but nationally, cases have been falling rapidly for several weeks after reaching record highs. Though infection numbers remain elevated, daily new cases are only 34% of what they were in mid-January of this year. We are now at new daily cases equal to the peak in January of 2021 and the lowest cases per day since December 27th. This is all really good news, but hospitalizations, while they are declining, they are still at 100,000 people a day in the hospital with the virus across the United States. Additionally, while we are certainly on a very good trajectory with Omicron, the US has lost more than 900,000 people from COVID-19 in 2 years, and more than 100,000 of these deaths have been in the past month alone. We are still averaging more than 2,600 deaths a day in the United States. In addition to the tremendous death toll, data now shows that the death rate in the United States is strikingly different than that of other large, high-income countries. The US had one of the highest death rates across the globe pretty quickly into the pandemic, though we were never the highest until the Omicron variant hit. Just since the Omicron peak, the US death rates are more than 30% higher than any other country. In fact, since the first Omicron cases in the US on December 1, the share of Americans who have died from COVID-19 is at least 63% higher than any other large, wealthy nation. And Americans are now dying from COVID at nearly double the rate of people in the UK and 4 times the rate of Germans, 2 of the countries with the highest death rates across this entire pandemic. So Dr. Del Rio, we're going to start with this really terrible statistic that represents tremendous loss across the United States. Do these data surprise you?
These data are very surprising and are very discouraging. First of all, because we know that vaccines are incredibly effective in preventing severe disease and death. Had we vaccinated those individuals, the number of deaths averted would have been very significant. But the second thing is, I think that it also talks about our enormous disparities, right? It talks about health inequities. It talks about the fact that we have a disproportionate impact of chronic diseases such as diabetes and obesity and others that significantly increase your risk of dying from COVID. And all those things combined lead to this very high mortality that we have. I do think that at some point in time, we're going to have to really look very closely at this high mortality, try to figure out what could be done differently. But I can tell you that when you think about pandemic preparedness for future pandemics, and there'll be others, I think one of the things we really need to work on are 3 things. Number 1, we need to work on chronic non-communicable diseases. We have to decrease the rates of obesity. We have to decrease the rates of diabetes. We have to treat hypertension. Those are going to be very important pandemic interventions. But the other thing we need to do is we also need to ensure access to care. I mean, the fact that people couldn't get tested back in December, the fact that there was such a difficulty getting a simple thing such as a COVID test almost 2 years into the pandemic, in my mind, is totally unacceptable. We should have been prepared for this wave. We should have enough testing. We should have enough availability of care and all the things necessary. I think we also took it nonchalant because everybody said, well, Omicron is more mild. And that was really a big mistake. It made people feel, oh, it's no big deal if I get this. And I think that also led to a very high mortality.
I agree with you. And we're going to talk some more later on today about the weariness that we all have from this pandemic. Let's focus a little bit more on some of the other points that you brought up. So, despite COVID-19 vaccinations actually beginning pretty early in the United States compared to a lot of these other countries, particularly compared to countries like Japan and Australia, a smaller share of the United States, of people in the United States, are now fully vaccinated. All other high income countries have more than 75% of the country fully vaccinated, while the US is at 64%. Additionally, less than 30% of the US is boosted, while all other high income countries are well above this, other than Japan, and they only began boosting in the last 2 months. Is most of this vaccination related, or is some of this about lagging booster rates as well?
I think it's mostly vaccination related. Boosting, while important, is not, if you look at the data for hospitalizations and deaths, it does decrease their mortality rate, but the mortality rate among vaccinated individuals is already pretty low. So it doesn't bring it down that much more if you're boosted. And in fact, if you look at the data that CDC has shown, boosting over people to people under the age of 65 doesn't really add a lot of benefit for mortality or for hospitalizations. So the reality is we need to focus on our very high risk individuals, people over the age of 65, where again have had the highest mortality. And we should have had not 75, but 100% of them vaccinated and boosted. And that would put us in a very different situation.
I'm glad you brought up that age group, because let's focus on them for a moment. When we began rolling out vaccinations in the United States, other than healthcare workers, people older than 65 were exactly the population that first had access to the vaccinations. And yet, only 12% of Americans over the age of 65 are still not fully vaccinated. And when we compare that to other European countries, we really see a striking difference. By contrast, England only has 4% of people over the age of 65 who've not been fully vaccinated. So, why are we still not reaching some of the folks that were some of our first priority people to get vaccinated?
Well, I think there are multiple reasons for this, but obviously the politicization that has occurred around the vaccines has played a significant role in it. And I think at the end of the day, we cannot forget that the politicizing something as a vaccine has really created a very, if you're vaccinated, you're in one group. If you're not vaccinated, you're in another group. And that to me has been one of the also enormous tragedies of this pandemic. We made things too political. When I've talked to colleagues in Portugal and other countries that have very high vaccination rates, and they say the key was to never politicize things.
Yes, it is super unfortunate, and it appears to be a place that we've gone and are staying. When we talk about hospitalized patients, the vast majority of them are unvaccinated. In the older population, though, are we additionally seeing the need for the boosters, and is that protecting those who are 65 and older from hospitalization?
It does bring the rate of hospitalizations down if you get boosted. So it does make a difference. I mean, I think, in general, if you think about it, I think about Omicron as a 3-dose vaccine virus. In order to have better protection, you're better off if you get boosted. So at the end of the day, boosting does make a difference with Omicron. I think, Omicron has taught us a lot about transmissibility. It's taught us a lot about immune evasiveness. It's taught us a lot about all the different things that have made, controlling this virus very difficult.
Omicron, I don't think is fully done with us. We're certainly still seeing a lot of cases, but we have a new subvariant to talk about. So the BA.2, just as we're seeing cases and hospitalizations across the United States declining, an Omicron subvariant, BA.2, is gaining significant traction in some parts of the world. Officials from the WHO suspect that Omicron BA.2 is likely to become the dominant strain worldwide due to its high transmissibility. None of us want to hear this news. BA.2 is rapidly spreading at this point in time across South Africa, India, England, and Denmark, where it is now dominant. In the United States, though, Omicron BA.2 is circulating at a fairly low level right now, accounting for about 4% of the cases, according to CDC estimates. So what do we know about the transmissibility of this new subvariant of Omicron? And is it just a matter of time before this becomes the dominant variant for us in the United States?
Well, I think that, we're beginning to learn. Tulio de Oliveira in South Africa has been looking at this very carefully. He's one of the really outstanding virologists there. And it is more transmissible. It clearly is more transmissible than BA.1, which is the Omicron original strain. But it doesn't appear to be more severe, and it doesn't have more immune evasiveness. So to me, the really important question of what's going to happen in the future is we really need to understand what's happening with natural immunity, with infection-induced immunity. Yesterday in the New England Journal of Medicine was a really interesting article from Qatar suggesting that natural immunity was very good at protecting you from infection caused by alpha, beta, delta. Was not that good for Omicron, only about 60% effective in protecting you from Omicron, but it still was very good against severe disease, hospitalization, and death. And if that's the case, we don't know really what the protection is going to be from Omicron. There is some preliminary data suggesting that it may not be as good. Omicron, as you know, is more of an upper respiratory infection, so it may not leave that lasting immunity. And I've seen people with Omicron reinfection that got Omicron and get Omicron again. Having said that, if we had the number of people infected in our country that we think we have, and there are different estimates, but some people say anywhere between 40 to 50% of Americans got infected during the last Omicron wave. And you add that to the vaccinated individuals, we may have enough sort of a immunological barrier to a BA.2 infection. We may see small outbreaks of BA.2, but we hopefully are not going to see what we saw with Omicron with close to 1 million infections per day. I hope that that's going to be the case because, quite frankly, otherwise we're just going to be going into this cycles of hypertransmissibility, hospitals overwhelmed, mortality, and we're going to have to think on a strategy very soon.
Absolutely. The term immune evasive properties is what we keep hearing about with this BA.2. And so there was also a Danish study that came out that found BA.2 was relatively better than BA.1 at infecting vaccinated people. Again, this leads to the idea that the subvariant might have better immune evasive properties. Can you walk us through what that actually means? And is that due to the large number of mutations that this particular variant has?
Well, the vaccines are very focused on the spike protein and a very specific component of the spike protein. And as that section of the virus mutates, then your antibodies against that portion of the spike protein are not going to be as protective as they were, particularly against a symptomatic infection. I think the other branch of the immune system that's activated by vaccines, which is the T cell response, that's different, and the T cell response is still pretty good. So you may still get infected, but not get severe disease or die if you're vaccinated. And again, at some point in time, we need to remind ourselves that the vaccines were designed to prevent severe disease and death. They were not designed to prevent infection. If you get when we talk about immune evasiveness, and we said the risk of symptomatic infection is still, it's decreased by 60%, but that's still a pretty good vaccine. I mean, the flu vaccine is not great at preventing you from getting infected, but it does a very good job in preventing more severe disease. So we got to think about what vaccines do for respiratory viruses. And again, at the end of the day, the goal of vaccination is to prevent severe disease, hospitalization, and death.
Thank you for reminding us of that. When we think back to when we were hoping what these vaccines would do, I think the goal was to see around 40% protection from severe disease and death. And so we started at such an incredibly high vaccine efficacy compared to what we had hoped for, that even when we see it diminished, we're still well above that threshold that we had originally thought this would be an amazing vaccine.
Protection against severe disease, hospitalization, and death, that you're right, we were looking for 40% or 60%. It's still holding about 90%. So I would still say that when we talked about vaccine effectiveness, we have to say against what? And against severe disease, hospitalization, and death, it's remarkably good.
We need to keep remembering that. And hopefully that will help those who've not yet made it all the way to being fully vaccinated to continue to realize why it's so important. We, as we are watching this subvariant and waiting to see what it's going to do and how much of it is going to come to the United States, mask mandates are continuing to fall across states that have even been some of the more cautious states with vaccination requirements and masking. And while COVID-19 hospitalizations have definitely dropped, we do still have 100,000 people in the hospital with COVID-19. And cases are declining, but we still have a lot of spread across the United States. In fact, currently, according to the CDC, more than 99% of all counties in the United States are still counties with transmission that are at the level that we should be masking if we're indoors in public spaces. So we know that we have this tendency to stop prevention programs when progress is being made, but before disease or infections are actually fully controlled. Is that what's happening here?
That's pretty much what is happening. I think people are tired. People want to get over this, and one way that governors are making decisions is by saying it's okay, take your mask off. Having said that, the reality is in most places, at least where you and I live, mask optional is where we are already. I mean, the reality is, except for work, except when I go to the hospital, and everywhere else I go, it's mask optional. So if you want to wear a mask, you wear a mask. If you don't, you don't. Go to the grocery store, go to anywhere, there'll be a sign outside saying, masks are recommended, but there's no mask police out there, right? So the reality is that, and then you see people, going to restaurants and people may wear a mask to go into the restaurant, but once I go inside, I gotta eat, so you take your mask off. So, at some point in time, you have to say what is the benefit we're getting from masking? And I think what people are really looking for is they're looking for off-ramps, right? They're looking for metrics. And I think we have been slow at giving metrics of saying, these are the metrics we're going to use to get masks off. I would tell you my personal impression is that I'm going to continue wearing masks in the hospital. I'm going to continue wearing masks when I get into public transportation. If I get into a subway, I get in an Uber, I'm going to continue wearing masks. If I go to get in a plane. But the reality is that most people are going to start, going to the grocery store and not wearing a mask. I think we need to realize at what point in time we need to make masks tolerable. I think we need to, we cannot have people, oh, you're wearing a mask and somebody's criticizing you for that, or the opposite. At the end of the day, we're going to have to understand that mandates around masks are not getting us where we need to be. And the reality is we need to think about what other interventions can be done. I want to see, quite frankly, if you want a policy intervention that I think will be more useful than a mask mandate, it's giving people paid sick leave. I mean, that will prevent a lot of infections. So that's a policy intervention that will significantly decrease infections. Give people paid sick leave so if they're sick, they don't go to work. Make tests available. Now the Biden administration has given tests to people. But if you want to go to Walmart or to CVS and get tests, they're still pretty expensive. And for the average individual, they're not affordable. So we need to make testing available. And then we need to link people rapidly to treatment. We have much better treatments in the outpatient setting that we still have not fully implemented. And I think if we implement that well, we may be able to do things that we're not doing right now. I think the perception of risk with rapid access to treatment is going to be very different. So the reality is we need to think about other things we can do to diminish risk, rather than, it's not just mask or no mask, it's just not vaccines and no vaccines. We tend to be very, we want to find magic bullets. And we think the vaccine is a magic bullet. We think a mask is a magic bullet. And the reality is none of them really is a magic bullet. We need to think about how to roll out multiple things that help people. I think looking at off-ramps and looking at metrics is something that health departments and CDC has to provide some guidance about what localities will be looking like. I agree that the decision to get masks off needs to be left up to the local authorities, because it's really hard to have, in one community you may be able to do it. I think in my mind, the things that will make it easier to get masks off is having fully vaccinated communities, highly vaccinated communities, above 75% of the population vaccinated, what you were talking about in Europe. Number two, and many communities in the US are already there. Number two is you need to have a decrease in cases, ideally, but somewhere below, around or below 30 cases per 100,000 population. Right now in Atlanta, we're about 45 per 100,000. So we're getting pretty close to that. Number three, I want to see the new hospitalizations from COVID down to less than 10 per 100,000 population. We're not quite there yet, but that would be a good metric. And then number four is we need to look at high ICU capacity. So our ICU capacity, is under 80%. I think that's a good metric. But the other thing is, CDC is now beginning to roll out wastewater surveillance. I think we can use wastewater surveillance to know where the virus is moving in a community and act before we actually see a huge spike in cases. So there's so many things that could be done. that could be more forward-looking than just saying, well, we're going to wait and then we'll take masks off and we'll be done. Because the reality is we're not going to be done. This pandemic is not over. There'll be new variants. And I think we need to have a multimodal intervention to really take care of this.
I fully agree with you. I do think wastewater management is so incredibly important because it gives us more information faster and it allows us to prepare. We now need it to ramp up our interventions again for a moment, or it's time to kind of slow them down a little bit and get used to this idea that things are kind of waxing and waning, and that we need to be in this dance with this virus for a little bit longer.
Think about the wastewater data and other data a little bit like looking at the weather report. You can imagine that you would wake up in the morning and see that DeKalb County wastewater is detecting more Omicron than usual. Or you may say, well, I'm going to wear a mask today. No different than when you hear there's clouds on the me, rain this afternoon. You say, oh, I may take an umbrella out. So I think you can use that information to make decisions in a much more effective way than mandates.
I think that's a really great way to talk about it. And additionally, what you've also helped point out is the CDC can make recommendations based on the science and the data, but local control is also super important. So those things are not necessarily fighting against each other. One is showing you where the data is and at that time, and the other is talking about, well, what's going on in our particular community. And those two things can happen at the same time together.
Absolutely. And again, it's down to local health departments, state and local health departments, to then implement the necessary activities.
Let's talk for a moment about trust, because what we're building towards is this idea of providing information that people can use, like a weather report, so that you can make an informed decision about how you will approach being out in the community on any particular day or time period. Yesterday, I heard a reporter call our country a culture of distrust. And I will say that was hard to hear and hard to think about our country this way, but it goes with a lot of data. A study published this week in Lancet found that a given country's level of distrust has strong associations with its COVID-19 infection rate. So really linking information like that to how countries have done during this pandemic. The authors actually stated the best way for the government to protect its citizens is to convince its citizens to protect themselves. Very much what you and I have just been talking about. So what are your thoughts on, additionally, about why we've not been able to do this well in the United States?
I think, again, we're highly polarized, and I think there's enormous distrust, and I think, that's going to need to be built. And I think, building back trust in public health, in my mind, is critically important. Number two, I think that, we have the emergence of social media, the emergence of fake news has really proliferated, and misinformation has been really has spread faster than any virus, and that has really caused a lot of confusion. I tend to tell people that quite frankly, what we have right now is not only mistrust and we also have a confused public. People are very confused out there, because again, even those of us that are trying to provide information, I will tell you one day one thing, and then the next day I tell you something a little different. And is that because I'm telling you, I told you a lie before? No, it's because science evolves, and as science is evolving, the information changes and the response change. So I think one thing that we also need to be better at is explaining to people the process of science and how science is made and how decisions are made based on the science that we have at that moment. The reality is, in an evolving pandemic like this one, I wish I knew today what I'm going to learn tomorrow, because I'll be better able to give you information. So I think one thing that CDC has lacked throughout this pandemic is communicating in a way that gives trust. In other words, a lot of their communication has been through press releases, has been through the web, and they really haven't done the good job of standing in front of people and explaining in very simple terms why they made this decision, showing some graphs, showing the science. I mean, the decision to go down to 5 days would have been made much easier if there had been some graphics, some explanation, and saying, this is what we know, this is what we're doing, this is what we don't know, and this are the studies we're going to do to try to understand this better. And I think understanding the process requires, explanations. It requires walking people through the process. And in my mind, that's also one of the things that are this these programs that you do actually try to do. We try to explain to people, we try to break it down so people understand what we're talking about. But people are confused out there. Americans are confused, and that is caused a lot of this mistrust.
Yes, I agree. And you're exactly right. This is exactly why we do these videos, to try to take small chunks of what we know and talk about them with people who are very good science communicators. So as always, I thank you for being with me and appearing so many times in these videos with me. Let's talk to lastly about another place of confusion, and that is the idea of endemicity, or an endemic level of disease. This is something I teach in classes, and something that is now a word that a lot of people are using and hoping that we're getting to. We certainly understand that people are expressing a lot of weariness about this pandemic and about the precautions that have been suggested to be used, while we're also still currently in the second deadliest period of this pandemic. So those are kind of competing issues going on right now. Again, it's human nature to want to remove prevention messages or measures when we see them working. But if we stop them too fast, sometimes that halts the progression that we were making. So as we talk about what endemic level of disease means, let's talk first about what it does not mean. It does not mean that the disease is mild necessarily. It doesn't mean that you've got milder symptoms, less transmissibility, or even low numbers of cases. Endemic levels really means predictable levels of disease that you can count on a certain amount every single period. So when we talk about the flu season, we have fairly predictable levels of the flu season at different points in time. So inherent in all of that is also the idea that we accept the level of infection as tolerable. So in your mind, using all of that as part of what endemicity means, are we really at a point where we should be talking about this level of infection and this level of death in the United States being tolerable and being our new endemic level?
Well, the reality is we started today, with over 2,000 people dying each day. The fact that we have tolerated that, we have made that the norm, to me is just mind-boggling. I could not understand why that enormous amounts of pain and suffering has been normalized. So the reality is we need to be outraged, right? We cannot accept what's going on. The problem is we've grown numb. We've grown to accept it. We're okay with hospitals being overwhelmed until we need to go there. And then all of a sudden we say, well, how come I couldn't get admitted? How come I was in the ER for 36 hours waiting for a bed? Or how come my surgery got canceled? But we don't see it. I mean, to me, I live in alternative realities. I live going to hospitals every day where the hospital is at capacity, is overwhelmed. And then I go out of there and it's like nothing is happening. So the reality is we have tolerated the level of mortality we have right now. We have tolerated the level of hospitalizations right now. So in our minds as Americans, we have said this is endemic, this is okay, let's live on with it. Now, the reality is, are we okay with that as public health experts? That's a very different question. And as a public health expert, the answer is no, this is not an acceptable level of death and mortality. I mean, I would like to see deaths from COVID down to 100 deaths per day, when, that would be about as many deaths as you're having with the flu. So if you get down to 100 deaths per day, let's talk about saying, okay, now we're in a more normal situation. The problem has been is that we've never been really that low. We've gotten as low as maybe 300 deaths per day. But then we have this enormous spikes, and we get this enormous spikes in great part because we're not prepared. We weren't prepared for the initial, outbreak. We were not prepared for the Alpha wave. We're not prepared for the Delta wave. The US was not prepared for the Omicron wave. So part of what we need to do in public health, quite frankly, is be prepared. I mean, why didn't we have enough testing when we knew Omicron was coming? Why didn't we do all the things we needed to do when we knew Omicron was coming? So the reality is, let's use this lows to get more people vaccinated, to get more testing, to get more drugs available. Let's be prepared, because there will be another wave, because the reality is there's still a global pandemic out there.
That's right. There is still indeed a global pandemic. So what we know now are infection rates are still high in most states, even though they have come down a very large percent Deaths will continue to be averted if we take precautions, particularly around those who are older and more vulnerable, and those who've not yet received vaccinations, and in areas with high spread. So, Dr. Del Rio, thank you so much for everything that you do to help us follow the science and talk about why we are suggesting certain measures of prevention and how we move forward. For everyone watching, please know that you can do things to protect those around you and to keep yourself safe. We hope you will continue to do that. If you've not yet been vaccinated, please find your way to a vaccination and a booster, and continue to think about wearing a mask when you're out in public, particularly now while we still have these high levels of spread, in public spaces can be very tight spaces to be in. Thank you, Dr. Del Rio, and thank you everyone for watching. Please stay safe.